Welcome everyone to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for November 21st, 2024. We have a really fun case today. I was pushing it hard in X, or what we used to call Twitter, because the pathology we have today is not something I don't think I've ever seen anything quite like it. Hope it lives up to my hype. We have a special guest, Dr. Jean Howe from Cedars-Sinai in Los Angeles, is going to play the role of David today and kind of guide us through the pathology and some thoughts that she has about some of the pathology and nomenclature and everything else. I think it's really interesting. The conference is being recorded. We have nothing to disclose, and actually today we don't. There's no. We haven't changed anything because I got complete permission from the patient to leave everything as is, dates, age, and even some pictures at the end. If you are not on our email list, let us know. We'll be glad to put you on it. And also, you check out our YouTube channel, Rush University Medical Center Renal Biopsy Conference, and we're getting close to having 100 biopsy conferences up there. So, and they're kind of categorized by the general topic as well. So if you're interested in, for instance, proteinuria, you can go to that area, et cetera. Thanks to Dr. Baxi, who's been our technical guru. This is a very long case, so I apologize for the many, many slides to get through it. And then I think today we will probably go well over the hour or two because there's a lot to discuss, but I think it'll be worth it. I hope people can stick around to the end. It's a long story. She starts in California and ends up in Chicago. So I'll read the protocol. The patient is a 24-year-old white woman, previously healthy, except for some anxiety on sertraline, who presented to her primary care physician in June of 2023 for some non-traumatic bruising. On questioning, her menses had become heavier and her gums were occasionally bleeding when she was brushing. Her doctor saw a few small bruises on her legs. A PT and a PTT were done, which were normal, and a CBC was done, which had a white count of 6.6. Hemoglobin was normal at 14, but her platelet count was borderline low at 146,000 being normal at that lab. Her CRP was normal. She saw the same PCP 6 months later in early 2024 and commented that the bruising was gone, but no labs were followed up at that visit. Then in 8/24, she lives in Chicago, but in 8/24, she went out to California for a wedding. And she ended up in an urgent care center because of swelling in her legs. It got pretty bad. She wasn't sure if this was exacerbated by the flight or not. She was hypertensive and her creatinine was elevated and her albumin was low, and she was sent to the hospital. And again, now she's in the LA area, where she was admitted. Upon further questioning, the edema started about 2 months ago, and she'd also had joint stiffness, a rash on her face, and a low-grade fever. Past medical history is as above. No surgery. She doesn't smoke. She drinks occasionally and smokes marijuana very occasionally. She works as a publicist. Her mother had endometrial cancer. Her father had melanoma, but both were doing well. She took only the sertraline. She not any non-steroidals or any over-the-counter medications, and she has no allergies. Her weight at the hospital now was 130 pounds. She was up 25 pounds from baseline. She's 5 feet tall. Her blood pressure was 150 over 110. Her pulse was 80, and her temperature was normal at 98.1. Respiration rate was 20. And she was saturating 98% on room air. She appeared comfortable. Her HET had a very mild myellar rash, no adenopathy. Her mouth and gums were normal. Her lungs were clear. Her cardiac exam was normal. Her abdominal exam was normal. She'd have 3+ pitting edema to the thighs, but no lower extremity rash. She had some synovitis changes in her hands, but this was commented only by rheumatology. So labs on admission there, her sodium was 130, her potassium was 5.1, her chloride was 102, her bicarb was 21, her BUN was 7, and her creatinine was 1.3. Her blood glucose, I guess this would be 110. Her calcium was 7.7. Her total protein was 5.4. She was hypoalbuminemic at 2.1, but the rest of her CMP was normal. Her CBC had a white count of 2.5 thousand, so she had some neutropenia. Hemoglobin was still normal, but her platelets were now dropped to 59,000, and they dropped to 38,000 even 2 days later. Her LDH was elevated at 442, normal being less than about 250, and increased to 528 2 days later. Her haptoglobin was less than 31, and normal at the hospital was 30 to 200. No schistocytes were seen on the peripheral smear, however. Our urinalysis had a specific grav of 1017, 3 plus protein, 3 plus blood, 15 to 20 white blood cells, and greater than 100 red blood cells. There were many granular casts. Her urine protein to creatinine ratio was 1.3 grams per gram. Adams TS13, cryoglobulins, lupus anticoagulant, beta-2 glycoprotein antibodies, double-stranded DNA antibodies, C3, C4, anti-GBM antibody, rheumatoid factor, SCL20, ASO, serum protein electrophoresis, ANCA were all ordered. Her chest x-ray was normal. Her renal ultrasound showed nonspecific, mild increased echogenicity. Kidney size was not mentioned. Cardiac echo was normal with an EF of 62%. Period. There was a trivial pericardial effusion, and they did leg Dopplers, which were negative for DVT.
Roger.
Next slide. Yeah. Yes, Dick. I'm
sorry.
More protocol coming.
Okay.
In the hospital in California, her blood pressure was treated with amlodipine and metoprolol. She received Lasix and albumin, and it was really ineffective. She was given methylprednisolone 30 milligrams twice a day, IV. On day 4, the double-stranded DNA came back at positive at 1 to 640. They had suspected lupus all along. C3 was 17, C4 was undetectable. Rheumatoid factor was normal. ASO was normal. Assess prep was normal. Platelets were now up to 154,000. Her hemoglobin was 9.6, which had dropped. Her white count was improved at 4.7, and her creatinine remained at 1.4. A left renal biopsy was performed by IR under CT guidance. She was discharged after a 7-day admission in California to return to Chicago for continued care. At this time, the biopsy results were pending, as were the Adams TS13, cryos, lupus, anticoagulant, beta-2 glycoprotein, anti-GBM, etc. Discharge medications were prednisone, 60 milligrams a day, Plaquenil, Lasix, 40 milligrams a day, sertraline, but she was not discharged on any antihypertensives. She arrived back to Chicago. It was seen by her primary care physician 4 days after discharge, who arranged for local nephrology and rheumatology consultations. They were, I think, going to be at about 10 days. Her blood pressure was 150 over 100 at that visit. Still not on any antihypertensive medications, but the physician said he just wanted to follow it for now. 12 days later, while awaiting her nephrology and rheumatology consult, she went to an optometrist for routine glasses change. This is just, she just wanted a new pair of glasses. And they thought the retinal nerve had edema in it. She was referred to an ophthalmologist the next day who confirmed optic nerve swelling, and she was sent immediately to our Rush ER. Her blood pressure on arrival at the ER was 180 over 120. Labs were ordered, and she was seen by ophthalmology, who confirmed papilledema and ordered an MRI. She had a tonic-clonic seizure en route to the study. A head CT was done, which showed some non-specific findings of, quote, focal gliosis. 2 hours after the CAT scan, she had another seizure, and she was loaded with Keppra and lorazepam. She then had a brain MRI, and she was sent to the floor. Shortly after arriving to the floor, she had 2 more seizures and was intubated and transferred to the neurointensive care unit. She had a few more minor seizures, which stopped after receiving more Keppra and lorazepam. Her MRI was read as a small hyperintense cortical-based lesion in the left temporal lobe, also seen on CT. A later reading mentioned press and possibly several small infarcts. These are the labs that were in the emergency room at Rush. Sodium 141, potassium 4.3, chloride 115, bicarb 10. This was right after her seizure. Her anti-gap was 16. Her BM was 73 and her creatinine was 2.3. So now when she left California, it was 1.4. Now it's 2.3. Albumin's 3.2. White count's 27,000. Her hemoglobin is 9.8. Her platelets are 147,000. Urine-specific gravity 1021. pH is 6. 4 plus protein, 3 plus blood. 42 whites, 29 reds, and a PC ratio now of 14.3 grams per gram. Remember, it was much lower in the past when they checked it. The pending labs, still from California, Adams TS13, ANCA, cryos, lupus, blah, 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 were all obtained and were all normal. Nephrology, as Dr. Corbett actually was on service, was consulted on day 2. I think it was his weekend on call. She was extubated that day with normal neurologic function. Her blood pressure was treated with hydralazine. She was treated with pulse solumedrol, 1 gram IV for 3 days, and placed on prednisone. And the results of the renal biopsy were obtained. It had been finished by the time, between the time she left California and by the time she arrived here. The results were available, but she was kind of in limbo between institutions. So I don't know if there was if the physicians in California even saw that. So Dick, you had a question? It's a very complicated story, but I wanted to present it the way we got it.
You answered my question, Roger. I have an additional question on the urinalysis, however. 3+ blood, and I presume that her serum was not pink.
Her serum was not pink.
And when this, well, I really want to know what her myoglobin is in the urine, but I'll defer that for later. Okay.
Roger, there's like no chance that she didn't get a pregnancy test, right?
She got a pregnancy test. It was negative.
It was negative.
Yeah, that's kind of ER number 1.
Was a spinal tap done?
It was done eventually, and it was normal. Yeah, it was done. Good question. Anything else?
Why do I feel like I'm going to get thrown under the bus here?
You're not going to get thrown under the bus. I've never thrown you under. Well, yes, I have.
Yeah, you have.
But not today, Steve. So poll number 1. What do you think this biopsy will show? Immune complex GN with or without crescents? Pauci-immune GN with or without crescents? Class 5 lupus with ATN? A TMA alone? Or number 1, 2, or 3 with TMA?
Having just had a discussion with Bill Whittier over this number 2, you sure you don't want to change that to some other terminology?
Like lupus vasculitis, maybe?
Yeah, I just, as Bill has educated me, he kind of discourages the use of pauci-immune in patients with lupus and prefers the term lupus vasculitis. But anyway, it's a question of terminology.
Thank you.
Remember, everybody can vote except the co-hosts, and nobody sees your votes, so. All right, we can show the results. Got a pretty good response here. And the overwhelming vote at about 70% is indeed number 5, 1, 2, or 3 with a TMA. It's hard to leave out the TMA given some of the story. It'd be interesting what people say if that wasn't part of it, 1, 2, or 3. But anyway, that's what we have. There's a few people that have number 1 and then really a spattering of just the others. 5 people thought it would be just immune complex GN with or without crescents. So next slide. So I want to hand it over to Dr. Whittier. I know Steve saw the patient. So Bill, why don't you tell us, what do you think's going on?
Thank you. Yeah, the way it's presented, it seems like it's going to be a pretty obvious case of lupus. We've got thrombocytopenia first, then you've got some acute swelling with a malar rash, some synovitis symptoms. You see the creatinine's up a little. The albumin's 2.1, and she's got a lot of edema. But then I think and that's certainly there in the differential lupus, of course, and the different lesions there that I'm going to discuss. But what's a little odd is that she has all this edema, and she only has 1.3 grams of proteinuria. And she's been ruled out for other causes of edema like DVT and so on. And so it's hard to reconcile.
Bill, subsequently, she had about 13 grams.
Okay. But I would say that, if even in the beginning, you shouldn't get edema before the 13 grams. You should have edema as a result of the 13 grams. And if it's possible that 1.3 was wrong. But if you see that much edema and a lack of that much proteinuria, it kind of makes you think of some other almost either nephritic GNs, like a post-infectious is the classic one, where you come in looking like heart failure, but you don't have a lot of edema. But you don't have a lot of proteinuria. Or another one, I mean, if you think about it, this woman sounds exactly like she has preeclampsia or eclampsia. She comes in with not an enormous amount of proteinuria. She's got bad hypertension. She has visual issues. She's got seizures. You know, it looks like she's going to have some sort of endothelial issue of her kidney and maybe in the rest of her blood vessels. And so I'm really kind of ramping up on my TMA part of the differential. We cannot ignore lupus. And so and I'm glad that you had number 5, you know, 1, 2, or 3 with TMA. And I think it could be any of them. I think that we are going to see some lupus nephritis. She has a new onset lupus, what it looks like to me. And she's so serologically active with a complement. I think it was like 13 or something. There's complements were on the floor. So I wouldn't be surprised if we see, you know, wire loops and very active immune complex mediated glomerulonephritis with crescents. But I think there's going to be something in her blood vessels that's sort of making her, you know, protein or making her so like, you know, sodium avid, yet not a lot of proteinuria. So I like the idea of thrombi alone. And in lupus, you know, that could be a lot of different things. You can have, you know, hyaline thrombi, you can have cryos. So I'm not sure what we're going to see, but I think it'll be something pretty interesting along with some crescentic lupus.
So what do you think's going on? I mean, the way I interpret this is that she's sitting there for 2 weeks with malignant hypertension.
Yeah, I mean, and that could be the cause of TMA too. I mean, she's really, like I said, I think, you know, she.
Okay, other opinions?
Bill, why did you put so much emphasis on crescentic disease in this patient?
You're right. She may not have crescent. She's got enough other things there to have renal failure. She might. I think she's going to be very immunologically active because she's so significantly hypocomplementemic, but that does not equate to crescents and lupus. So she may not. I just know serologically and systemically she's very, very sick. But I think her renal failure could also be more, you know, thrombotic or vascular as opposed to crescentic. You're right about that, Dick. Thanks for pointing that out.
What do you think, Bill, is going on with her brain?
Yeah, I mean, she's having seizures. I know you asked about the LP, but I was sort of thinking that's why I was considering some sort of almost eclampsia-like lesion, right? Some sort of endothelial thing that seems to be going on in her kidney and her blood vessels causing malignant hypertension. It could probably be press. You know, I can't remember if we got an MRI that might have showed that or not, but
I mean, lupus.
What about the microinfarcts?
mm-hmm.
And because the other consideration would be lupus vasculitis,
mm-hmm. or
affecting the brain.
Mm-hmm.
Yeah, sure.
I mean, lupus patients can get a TTP-like syndrome as well.
Mm-hmm.
Her Adams
Not necessarily being
was
Adams.
negative, right?
Pardon?
Does the Adams T13 that was negative?
That was negative.
Yeah, but I don't know that it has to be positive in patients with lupus.
I don't either. I'm just throwing in there to ask for a response. Does anybody know whether it has to be positive in lupus or not? I don't know.
I don't think it does. I remember that paper years ago, you know, TTP like in lupus, but I don't think it was. I think it was before they really understood some of the pathophysiology of these small clots.
Yeah, but I think if you have clots there and your Adam TS is normal, you couldn't call it TTP, but there would still be a TMA. You know, and that could be TMA from malignant hypertension. It could be TMA from, you know,
well, I think that's the $1 question, right? Is hypertension driving the process, or the thrombi, you know, the TMA driving it? I have a feeling it's the TMA that's driving it, given her history. I mean, the only thing she was on before all of this was Zoloft.
And it seemed to be that the nephrotic syndrome type presentation predated her significant hypertension, or am I wrong on that?
she had a low serum albumin. The urine protein creatinine ratio was actually not that bad. It's kind of
Right.
interesting.
Yeah, that was
whether the hypertension may have driven the proteinuria too, which we can see.
You know,
Yeah, I think it's.
my question of Bill earlier about crescents was motivated by the fact that I know it's anecdotal, but in crescentic disease, malignant hypertension is rare as hen's teeth. It just doesn't occur. I mean, I've seen patients with good pastures, with ankylosing, enormous amounts of crescents. The blood pressure is normal or slightly elevated. It's not malignant. This patient has some other vascular disease that is going on concomitant with her lupus that is completely independent of any likelihood of crescentic disease, in my opinion. Now, Mario raised this issue of lupus vasculitis, and I'll show my age. By old autopsy studies done many, many decades ago of patients dying of lupus with cerebrovascular manifestations, vasculitis was rare. In fact, what was mostly seen was fibrinoid necrosis and thrombosis, microthrombi, not necessarily related to platelet thrombi like you'd see in PTP, but fibrinoid necrosis and thrombosis of the small vessels without any sign of an inflammatory vasculitis in the brain.
And that exists in the kidney too. There's a whole realm of lupus vasculopathy that's not necessarily the same as the segmental necrotizing vasculitis lesions that we might see. That may just be thrombi, or you can even have, sometimes you can have a medullary angiitis or something too, but there's a whole almost class or subclass of lupus vasculitis and definitions of that. Sorry, lupus vasculopathy, misspoke.
Yeah.
Yeah, I was, it's interesting, all this discussion, because, when I read through the case, this woman, she's out there, she's hypertensive for a couple of weeks, nobody puts her on anything. And then, then she has she has papilledema that's an optometrist, not to offend an optometrist, but an optometrist picks up that papilledema, and she starts seizing like crazy. To me, this is cerebral edema. This is malignant hypertension in the brain. But yeah, there could have been the MR and the CT findings were very non-specific, or at least it used language I couldn't quite understand. So there was no bleed. They said possible some small infarcts, which I think Dr. Rubin was referring to.
Yeah, I mean, look, there's no question this is like the TMA process, whether it was malignant hypertension, scleroderma, whatever you want to, say the inciting issue was, or lupus. I mean, she's got big time intravascular hemolysis with thrombocytopenia. It's interesting that she had schistocytes and thrombocytopenia before she ever had anemia. It's kind of your original, as you were going through the protocol, the hemoglobin was 14, and yet she had thrombocytopenia. Half the globins were on the floor already, and she had, evidence of intravascular hemolysis. I thought that was kind of interesting that there was clear evidence of that, and despite that, she didn't have anemia, but then went on to develop that.
Yeah, she did drop to 9 here, but yeah, from 14, so that was a big drop. But let's move on because we have a lot to go over. I think it's time for the path.
Yep.
Put the wheel up. We'll see.
Oh,
All
man.
right, Bob.
Give me a second here, Bob. Now I'm going to give you
Bob is one of our second-year fellows.
host.
I'm just curious, was the Coombs test done?
Oh, I'm sure it was.
You think this is autoimmune?
Well, it's in the differential, although TMA can be the responsible agent here.
Yeah.
Second here, Bob. Not making me do.
You can hear me?
Yes, we
Yes,
can.
we can hear you. Let's see. Now you should be able to control. Let's see. Go ahead, click on the
And
screen.
Mario, while you're
There you
waiting
go.
for that, Mario,
Move your mouse. Well, there you go. Yep, that's you.
Okay.
Okay.
Okay. Okay. So I see 3 cores here. Several glums. Can't really comment on them at this power. I don't really see any fibrosis.
It was minimal in this case.
Okay. So we have a silver stain, 1 glom here. There's a lot of cells within the capillaries that I can see. So a lot of endocapillary proliferation. Always maybe some double contouring. It's really hard for me to tell that at times.
This patient looks like pregnancy.
Do you see the muddy brown looking material?
Right here in
Yeah, what is that?
Could it be like a thrombus within the capillary?
It is a thrombus, yes, but it's not a fibrin thrombus.
Okay, that would be more like pink.
Yeah, well, from on our silver stain, fibrin is bright pink. This muddy brown material is much more consistent with immune complex deposits.
Okay.
Yeah, so that you're looking right there at an intracapillary immune aggregate.
Okay. Okay. Thanks, Dr. Howe. And then the tubules around, I don't really see anything with them.
And there are different types of inflammatory cells. Can you go back one again? In that distended capillary loop down at 4 o'clock, you see the nuclei are the blue circles, and there's a couple nuclei that are much darker and they're kind of multilobulated.
Like here?
Yeah, do you know what cell type that is?
That would be like a neutrophil. If
Yeah, exactly. So it's a mix of inflammatory cells that includes neutrophils. That's relevant in this case.
What's in Bowman's space at 3, 4 o'clock?
That is a podocyte. You mean with the dots, the muddy brown dots that are in the cytoplasm?
Well, I see the structures that are filling Bowman's space in that the arrow just went by there.
So the cells that are directly lining Bowman's space, those are the parietal epithelial cells, and they're a little bit revved up here. And then if you move down from Bowman's space, that big cell that has the that has the round dots, that's a reactive podocyte. And those dots are protein reabsorption droplets.
So you have both visceral podocyte reaction and parietal cell reaction, right?
Yes, but this is not a crescent.
Right, pseudocrescent, as it used to be called.
No, but I think what Mario's trying to point out is this an early collapsing lesion with podocyte hyper expansion and undifferentiated podocytes in Bowman space.
For the collapsing lesion, we like to see what we call deflation of the underlying tuft, and it can be very difficult in a case like lupus where you have a lot of inflammation of the glomeruli. But for a true collapsing lesion, we also like to see true parietal epithelial cell hyperplasia. If you look at the parietal cells, they're lining Bowman's capsule, it's just one layer. So for a true collapsing lesion, we'd like to see, a proliferation in those cells. And the podocytes often will have these large cytoplasmic vacuoles. I can see why it may appear to be, but I would not yet call this a collapsing lesion.
So right dead center, is that another thrombus?
Right here?
Yeah. That is a subendothelial deposit. And this is actually one of my pet peeves is that the term hyaline thrombus is one of the features of activity for lupus nephritis, but it's a misnomer because it is neither hyaline nor is it truly a thrombus. So it is actually a large immune complex deposit. And the thought is that what look like they're true circulating immune aggregates or immune thrombi are actually gigantic subendothelial deposits that have gotten so large that they've grown down into the capillary lumen. And when you section them in certain ways, it can appear that they're sort of floating around and including the capillary lumen, when in fact, what they are is actually large subendothelial deposits. You can actually see it there. You can see how
it is interesting though. It doesn't look like a wire loop, what we used to call a wire loop.
No,
right?
that's a wire loop. That's a wire loop gone wild.
Yeah.
The mother of all wire loops.
Yeah.
Okay. Okay, we see another silver stain. More of that, I guess, not like a immune complex deposits. See the double contour. Yeah, I'm just seeing more of those even in this glom here.
And actually up at 11 o'clock, that big immune aggregate, you can see how it's actually growing down from up one a little bit. The aggregate to, yeah, right there. You can see how it's connected. It's a subendothelial deposit that's grown down into the capillary lumen because you don't see the double contour that would otherwise, or, you know, the second GBM that would be there if it were truly an intracapillary circulating aggregate.
It's interesting too, in this same glom, if you go down to around, I don't know, 6 o'clock going to 6:30, that capillary loop, there's the black stain, there's the basement membrane, then there's the pink material, which I assume is a deposit. That's the wire loop there. And then
that's the wire loop.
Then you've got a second membrane that's being laid down as well. So you definitely see another black layer that's going to be your double contour.
Yeah, the wire loop is basically an immune complex deposit sandwich. It's sandwiched in between the two GBMs.
Yeah. Oh my.
We see more of the immune complex deposits here. Oh, sorry.
And if you didn't tell me this was a lupus patient, I would look at this and I would say, you know, this looks like a cryo-GN. You know, it's really striking.
Yeah, sure is.
And what you're not seeing, I should note, is that these are all immune aggregates. What we're not seeing are fibrin thrombi in the glomeruli.
And we know that why, Jean?
Because the fibrin has a different color on our silver stain. It's a really bright, bright, bright pink red.
It's a wonder she has any GFR.
Yeah. You try to perfuse that glomerulus.
Yeah.
So does the trichrome stain help you differentiate immune complexes versus fibrin thrombi?
Yes, and you have to, the key is to become familiar with the properties of your own staining in your own lab, because a trichrome stain performed in a different lab will be slightly different. So I am very familiar with the colors and the different properties that our stains portray. So a trichrome, we'll show trichrome in a little bit. Yeah, there is a difference. You can differentiate fibrin from immune complex deposits basically on every stain.
Thank you.
It is interesting, Jean, how there's no crescents and no capillary wall breaks.
Not yet.
Okay.
But I mean, the fluorescence would also distinguish, right?
We have an H&E here. I see more of like the wire loops here.
And concentrate on the center of the screen.
Right here.
Those are the wire loops. And then just below that, there's that, below that even, in the right dead center of this, right there, yeah.
Periactic debris?
Yeah, great.
Okay. Is this more of like these are still the immune deposits?
What we call hyaline thrombi and lupus, but yeah, they're all immune. And you can see how they all have the same staining property. They're very brightly eosinophilic and waxy and dense.
Okay. Okay, and then we have another Jones stain, more of the immune deposits. I mean, this area looks a little.
Yeah, where is that located and within the anatomy of the glomerulus?
Oh, wait. This doesn't look like the hilum though. Right.
No, it's not.
No.
It's in the urinary space.
Oh, okay.
You see, Jean, Dr. Glasser, who has ESP, because I was thinking about a collapsing phenomenon. If I look at this, I see shriveled glomeruli structures with material filling the space, Bowman space. So I begin to think along the lines of collapsing. Why isn't this an early form of collapsing GN?
So we don't see really reactive appearing podocytes here. So there's no podocyte hypertrophy with the cytoplasmic protein absorption droplets and the really large vacuolization. And the other thing that I don't have control, but I can't point it out to you, there is actually, if you follow the silver stain, there's a point where the GBM has ruptured. So you can see the truncated ends of the GBM. And that is a sign of crescentic injury, or what happens, or why the crescent forms is the GBM ruptures, and then in an attempt to repair itself, that's the formation of the crescent. It's, again, I can't
Gene,
Is
is
it
that
right
what?
here?
Also,
Is
the
that-
glomerular, the capillary lumens aren't collapsed. They're actually filled with stuff.
Exactly. But you can
And
have
this
you
is
can
the
have
GBM.
collapsing lesions, like for instance in diabetes. It just becomes really, really difficult to distinguish the two. But here there is a clear GBM break, and there is a cellular proliferation in the urinary space. It doesn't look like your typical parietal epithelial cell hyperplasia or reactive podocytes that you see in a collapsing lesion.
So do you see the rupture somewhere?
I do. Actually, I
Is
can't.
this what you're trying to point to, Dr.
No,
Or
no.
okay.
Can you give me control?
I
Can
don't
you
know.
put, can you change the pointer to a laser pointer? Maybe it would be easier to appreciate it.
Dr. Baxi.
Can you
But,
see my?
Gene,
Can you see me?
if you click on the screen, oh, yep, you're controlling the screen. Go
Okay.
ahead.
So here's Bowman's capsule out here, and here's your cellular proliferation. Right here, you see that curve right here?
Oh my God.
That's actually, that's a GBM, and you can see where it's truncated. That's where the rupture happened. Right. So as the GBM ruptures and things that, all of a sudden have access to the urinary space that don't belong out there. And it turns out that there's a real, inflammatory milieu out here. So as the fibrinogen comes out into the urinary space, it gets cleaved to fibrin. And then your parietal epithelial cells, they realize what's happening. There's a stem cell population there. They march down to the site of injury and they dive down. You can almost see it diving down. And that's why sometimes these crescents have a wedge-shaped appearance. So they dive down to the site of injury and proliferate. And you can actually see right here, that's a mitotic figure. That is a parietal epithelial cell in anaphase, actually, right? So they're pulling apart.
Wow.
Yeah, so this is a fibrocellular crescent, and it's fibrocellular because you have a mixture of fibrosis and cellular proliferation. So it's not a super acute crescent, it's what we call maybe like a subacute crescent. So yeah, that right there.
Gene, I'm sorry. I was taught, and maybe it's there, and I'd like you to point out that in order for you to call a structure a crescent, you need to have 3 layers of cells.
Mm-hmm.
Are there 3 layers of cells there? I just don't see them.
It depends on, so yeah, there's 1 layer here, 1 layer here, and 1 layer here, or 1, 2, 3. It's a soft rule. It's more looking at the pathophysiology of why the crescent forms. And to me, having that GBM break here that I can see, evidence of prior GBM rupture and repair, that for me nails it. And who knows, on a deeper section, this crescent might actually get bigger. We're just looking at one slice in time here.
But in some of these studies you look at where they describe crescents, they talk about not only how many cell layers deep, but what percent of the circumference is involved with it.
Yeah.
Gene, there's a question in the chat about 2 o'clock. Is that the proximal tubule or is that the
No, this is the takeoff to the proximal tubule, the tubular pole rather. All right, you're doing great. Keep going.
People, let me see if I can give 2 people control here. Give me a second here.
You're like air traffic control.
Okay.
Go ahead, actually. Go ahead, Bhavna.
Okay. Perfect.
And here, focus on the contour of the GBMs, the external contour, subepithelial.
So you can see the double contour here. I don't see the same deposits that we were seeing before.
And then look at the external surface or the subepithelial surface of the GBMs. Do you notice anything unusual?
Oh, yeah, there's some holes here, and I see some spikes here as well.
Yeah.
Spikes and holes.
So what do you think is going on?
That there are subepithelial deposits
Mm-hmm.
and subendothelial deposits.
Mm-hmm.
Lots
This is the membranous component.
Yeah.
I mean, this is part of the glom. This kind of looks like the hilum area.
Yeah.
So this should be the arterial.
Mm-hmm.
I mean, there's 2 colored kind of deposits.
Compare it to, can you see my pointer here?
No,
that's okay.
No.
The muddy
comparison to this.
Yeah, compare it to that. So it's the same color, right?
Yeah, but there are some darker areas.
Yeah.
That I actually don't know what that is.
That's just a variation in the silver stain, but the main component of those things that you're seeing on the walls of the arterial or what?
Would be immune complex.
Yeah.
Okay.
Lots of immune complex deposits in the vessels. That's the afferent arterial.
So if the afferent arterial has, almost occluded by immune complexes, that would make the glomerulus ischemic, and it would also then maybe one of the reasons it was kind of shrunken and wrinkled.
It's possible. Mm-hmm.
Bill's bloodless glomerulus from a different reason.
Go ahead, Bhavna. Just click on the screen.
How do we know that's afferent?
I'm assuming just by virtue of the fact that the afferent arteriole is where your if your blood is full of immune complex deposits, right, that's where it's going to hit first. So you tend to have more accumulation of these immune complex deposits in the afferent as opposed to the efferent. But you have a point. You know, I don't know 100% that that's the afferent arteriole.
You kind of imagine the same thing happening in the brain.
Yes. Yes, it's kind of like amyloidosis. You know, if you see a really bad case of amyloid in the kidney and the same patient has a hemorrhagic infarct, those blood vessels in the brain are extremely brittle. So I would have to assume that this is not the only vascular manifestation of this patient's disease, not just in the kidney, judging from how severe this is anyway.
Sorry, trying to move. Okay. Similarly, we see another afferent arteriole with deposits. But I mean, the deposits don't look as...
No, they're floating, or it looks like they're kind of floating around in there, but the key is that arteriole is markedly distended. It's quite distended, and it's a mixture of immune complex deposits and likely some proteinaceous, material and some red blood cells. I don't actually see fibrin in there yet, but it looks like it's plugged up. It looks like it's just really, it's very, very distended.
Okay.
Occluded, yeah. Here.
So I don't actually know what the stain is.
This is a trichrome stain, and when the person took the pictures, they overexposed it to really draw the contrast. So what you're looking at is basically the same glomerulus as you saw in the previous picture, just a different stain. So that was a silver stain before, and now this is a trichrome stain. So you've got the arteriole again, and the key is to look at the different colors. So you see, what two colors do you see there?
The orange and kind of like a bright pink.
Yeah, so the orange would be the immune complex deposits, and the bright pink is fibrin on our trichrome stain. So this is the first evidence of true thrombosis, fibrin thrombus, in a vessel that also happens to have a ton of immune complex deposits. So this is a thrombosed arteriole, and then you can see downstream what does the rest of the glomerulus look like downstream of this occluded arteriole.
Yeah.
It's deflated, right?
Like shrunken?
Ischemic, yeah, because of that vascular occlusion by the thrombus and the immune complex deposits. So downstream glomerular ischemia.
And then we have immunofluorescence, which is positive for IgG kind of everywhere, but in these the capillary loops.
Those are the immune aggregates, yeah.
And then you see some around, I mean, they're kind of positive all over, but more so in the capillary loops.
But also in the GBMs, right?
Yeah.
In the mesangium.
In the mesangial areas as well. And then look outside of the glomerulus. Can you see that? Yeah.
Like a tubule or pericapillary?
That's actually probably another neighboring glomerulus, but I'm talking about the faint staining in Bowman's capsule. You see the granular IgG in Bowman's capsule as well. The circle that encompasses the glomerulus.
Like right here.
Yeah. They follow that all the way around. So this is one of the signs, or one of the things we look for in lupus nephritis, is that oftentimes you can have deposits that aren't just in the glomeruli, you can have extraglomerular deposits as well. So in Bowman's capsule, sometimes you can see them in the tubules, sometimes you can see them in the vessel. So that's another key if we're looking at a case that this may be lupus.
So Jean, along those lines, and I'd like to hear your thoughts. I heard today from a pathologist in the Northeast that when you have extraglomerular IF deposition of immunoglobulins and you're dealing with the membranous, that's a hint that you're dealing with secondary membranous as opposed to primary membranous.
Yeah, or what we used to call primary. Now it's antigen driven, right? But
right.
yeah, that's one of the things that we evaluate for. If we see extraglomerular deposits, that's much more indicative of some sort of secondary, either likely autoimmune or maybe an infectious etiology, rather than an antigen driven membranous like PLA2R, which is limited to the glomerulus, right?
Sure.
Mm-hmm.
Thank you.
And then C1q is positive as well, in the capillary loops as well as the mesangium.
And then you can see even stronger staining in the interstitium, Bowman's capsule and tubular base membranes. In this particular case was full house. We're just showing the IgG and C1q.
This doesn't look like a glom.
It's not a glom, no.
It's like, I mean, this looks like the glom. So it's probably like an artery?
Yeah, arterial. Yeah, good. And what does it look like?
I mean, closed off, like you see a lot of immune complexes.
Yeah, so here's the IF correlate of the light microscopy that we're seeing. You know, those arterioles are completely, caked with immunoglobulin, in this case, IgG. Good.
We didn't see any vessels on the light microscopy. Do you have pictures of that?
We saw arterioles. We didn't see large vessels or arteries, no.
So there was no evidence of fibrinoid necrosis of the vessels in the biopsy?
No, not true necrotizing, like inflammatory vasculitis, no. There was some mild arteriosclerosis, I believe, but there was no vascular inflammation or inflammatory injury in any of the vessels sampled.
And then we have EMs here. Podocytes all look good. We have the urinary space here in the blood. There's massive deposits here, so subendothelial.
Mm-hmm.
We have subepithelial scattered deposits here. And then this is the mesangium.
Yeah, that's good, actually. And this is something else that we look for in lupus nephritis, what we call 3-location deposits. So they say, like, for instance, in primary or podocyte or, antigen-driven membranous, that the deposits should only be along the subepithelial aspect of the GBMs, nowhere else in the glomerulus. When you start seeing deposits in other areas, including subendothelial, mesangial, outside of the glomerulus, then you start thinking of secondary etiology. So this is a beautiful example of those 3-location deposits that we look for. Good.
Is that villus transformation in there as well?
Yeah, the finger-like projections in the podocytes, that's what we call microvillus transformation. And we see that not just in membranous, but also in like minimal change disease case settings where there's profound proteinuria. You can see that microvillus transformation of the podocyte cell surfaces. They're like finger-like projections. They're in the urinary space.
Oh, like here.
Are you a pathologist?
No, I'm a amateur nephrologist.
Okay. The EM with the subendothelial deposits here.
Mm-hmm. And then the sub-IV, but below that, yeah, where your arrow is right now. Where are we in space? Below. Yeah, right there.
Okay. This should be like the capillary loop.
Yeah. So that's a close-up of the immune thrombi. The one thing that we should note is that at a higher power, there is no organized substructure. So in some cases of lupus nephritis, the deposits can sort of spontaneously organize into what we call fingerprint structures, or sometimes you can get lupus type tubules, and it's something that's very particular for lupus, especially the fingerprint structures. But there really was no organized deposit here. Certainly, we don't see anything that looks like cryo, right? Because that's on the differential. When you see those big, occlusive immune aggregates, you want to make sure that you're not missing a cryo. And cryo has a very particular microtubular, hollow core structure, curvilinear. None of that. No organized deposits. So these are just kind of your generic immune complex deposits. Good.
Is that the flocculent material that is described in the subendothelial area in TMA?
No, in TMA, it's electron lucent, so it would be very clear. It would look more kind of like the cytoplasm in the cell that's underneath the podocyte, like it's where it's really clear. That's sort of the staining property in a TMA, but I don't see any subendothelial lucencies here.
Okay.
Huge deposit.
This I can't, so we have more deposits here. So endothelial. This looks like a huge deposit.
Yeah, it is. It is.
I mean, this is a mesangium.
Yeah, and
Right.
the one in the middle is floating in the capillary lumen, so it's an immune aggregate, just another one. You can skip this one. And then here, really, it's the structure that's in the middle, just south of the middle.
Oh, that's a TRI.
Yes, it's a tubular reticular inclusion. Yes, and we definitely want to see those in lupus nephritis. I spent hours down in the EM lab because I can't sign out a case until I find these. But yeah, good job. Now what are we looking at? It's not a glom.
Is it a vessel?
Yeah. What do you see?
Kind of diffuse circumferential deposits, like immune deposits.
Yeah. So that's one of the arterioles that has massive vascular, vessel wall immune complex deposition. And you won't be expected to know this, but in the middle, there's a red cell that's floating around, but just to the right, those wispy looking things just to the right, those are fibrin tactoids, right? So that's fibrin. So that's evidence of some sort of fibrin, either in the plane or out of the plane or something, not quite here, but there's evidence that there is fibrin circulating as well. You nailed it.
Good job.
Thanks for your help, Dr.
So what's your pathologic diagnosis?
I've never seen it before. No, but immune aggregates filling up all the capillaries. I would call it, I guess it's a thrombotic microangiopathy of sorts, or a lupus vasculopathy, but it's I've never seen anything quite like this. There's also segmental necrosis, also the beginnings of crescent. But I think that, the main pathology is in the blood before the glomerulus.
What about the membranous component?
Yeah, sorry, and membranous too. Podocytes were pretty good.
They're along for the ride.
I'm sure it will be described more eloquently by Jean.
Great.
I don't have a PowerPoint. I'm just using yours.
You can bet whatever you want to bet. These deposits originated in the circulation and didn't form in situ. This is a circulating immune complex disease of profound vascular nature, and this will raise a question about treatment, I think, in a minute.
Well, do you think there are more than one type of antibody that's present here? Because with that membranous component, we talk about, the high affinity and low affinity antibodies in the dissociation and then the formation of those membranous deposits in situ as opposed to subendothelial. I think there's more than one immune process going on here.
But certainly it being there in the afferent arteriole really proves that it's something in the vascular system as the primary driver of these immune aggregates.
Thank you. Thanks, Jean, for joining.
Yeah.
It's a pleasure.
Thanks, Jean.
We can see your screen.
Interested
Make a
to see how
PowerPoint.
Steve and Bill feel that
there we go.
Biopsy findings modify treatment decisions.
Oh, did I do that?
I did that.
Oh, okay.
I'm going to hand it back. For the sake of time, I'm going to hand it back to Jean. She wanted to discuss a little bit about this whole nomenclature that kind of Bill brought up initially. I think it has to be in this mode. I'll just advance for you.
Yeah, you can do it. Yeah.
You can see this beautiful sunshine there. We're in the middle of a blizzard here.
The sun shining behind me. So here's the final diagnosis. There were 26 glomeruli total. So 23 of those had active or proliferative lesions. So that's 88%, which is greater than 50. So already we're at a class 4. 12 with endocapillary hypercellularity, 3 with neutrophils and karyarexis, 19 with wire loops and or hyaline thrombi, and only 3 had small fibrocellular crescents. And then all the glomeruli had a membranous component, and there are actually, criteria that we have to meet. So that means that greater than half of the glomeruli have to have at least 50% surface area by those subepithelial deposits to call it a membranous. So we have a 4 plus 5. Next slide. So we do the activity chronicity index here, or I do because this is just the way that I was trained. You know how each one of these features is an active feature that we have to evaluate every single glomerulus for every single active and every single chronic feature. And it's done by quartiles, so 0 to 25, 25 to 50, and greater than 50. So endocapillary hypercellularity, 12 out of 26, was just less than 50%. So that's a score of 2 rather than a 3. So if you go down, you can calculate it out yourself. The 2 that get double weighted because they are more serious would be the fibrinoid necrosis and active crescents. We take the score and multiply that by 2. So adding all this together, the activity index was a 9 out of 24. And there was no chronicity because there were no globally sclerotic glomeruli, there was minimal parenchymal scarring, there were no fibrous crescents. Next slide.
Seems like a really low score for what I saw.
It does, but that's because there's a lot of wire loops and hyaline thrombi in this case, and just there wasn't a lot of active crescent formation and not fibrinoid necrosis in the glomeruli anyway.
Yeah, I think that's an unfair activity.
Mm-hmm. Take it up with the NIH.
That's right. Howard Austin's already retired, so I don't know you're going to get much from him. But...
So this is my plug. I always give this for the activity chronicity index. I use it. I was trained to do this, and the clinicians that I work with, some of them use it, some of them don't. Some of my colleagues use it, some of them don't. And this is my point. You know, let's say you have 10 glomeruli, and one of them has an active lesion. And this particular glomerulus has fibrinoid necrosis, cellular crescent, and endocapillary hypercellularity, just for argument's sake. So on the top core there, you have 1 out of 10 glomeruli. That's a class 3. On the bottom core, you have 4 out of 10 glomeruli. That's still a class 3. Is that the same disease? No. And if you look at the activity chronicity index, the activity index of the top glomerulus, if you multiply it out, would be a 5, right? Is that the same disease process as, the bottom core where you have 4 glomeruli showing these lesions, and all of a sudden, if you do the math, the activity index goes to a 10. So just simply looking at the class score as a class 3 versus a class 4, I don't think gives a really good indication of what the actual activity of the disease process is. Having the activity index is really great for not only just one, it's probably not as useful for a single snapshot, but it may be helpful as you know that these lupus patients often undergo repeat biopsies over and over and over again. It's just something sort of subjective that you can track over time. So that's my plug. I won't say anything more about it. Next slide. This is just, I show this, I'm going to give you an insight into the madness that's in my head. The difference between a class 3 and a class 4 for the most part doesn't really matter. However, if the difference is between a 16-year-old female that's going to get Cytoxan and not, I want to make sure that I give them an accurate score. So lupus nephritis is not a trivial thing to score because each one of these glomeruli, I have to look at it and I have to ask, have you been touched by lupus? And if so, how? So if one glomerulus has this crescent, an endocapillary hypercellularity, a wire loop, that glomerulus gets count 3 different times for the activity and chronicity index. So in cases, and I tend to do this with pediatric cases and those high risk cases where it may be the difference between Cytoxan or no Cytoxan in a female of reproductive age, I actually do this. I map out the glomeruli, all 10 levels. And so by the end of my case, I've seen every single glomerulus, and then I go back and I count and I do the calculations that way. That's just me. I'm insane. Not everybody does this, but this is just to give you a sense of how tedious these cases can be. Imagine a pediatric biopsy with 220 glomeruli trying to do this. Next slide. So the final biopsy diagnosis, next. Diffuse and active membranous lupus nephritis, next, class 4+5. And then this is acute thrombotic microangiopathy. So even though many, many vessels had those immune complex deposits, the actual fibrin thrombosis was only seen in 1. So, when we talk about TMA, we usually give a large differential, malignant hypertension, TTP, HUS, you can read all that. All of these can appear histologically identical. I, as a pathologist, cannot tell you what caused the TMA. All I can tell you is that there is a TMA. Next slide. Or next, click. TMA is a clinical diagnosis because from my perspective, the pathologic findings of TMA can look identical, regardless of the inciting cause. And it's all a result of endothelial cell injury. And even that term thrombotic microangiopathy is somewhat of a misnomer because you can have TMA without thrombosis. We see that all the time, where you have severe endothelial cell injury in malignant hypertension, for instance. So it really is a clinical pathologic diagnosis. Next. So this brings up the term lupus vasculopathy. And so I probably should have had Bill talk about this, but scroll to the next. So what is it? Next. If you go back, the original really good definition was, Jerry Appel and Vivek Dagati years and years ago. Next. They subdivided the vascular manifestations of lupus nephritis into 5 categories. Click again. And you can see them down here. So uncomplicated vascular immune complex deposits. So those vessel wall deposits without any other pathology, non-inflammatory necrotizing vasculopathy, which is a terminology that I don't particularly agree with, thrombotic microangiopathy, and then true renal vasculitis or vascular inflammation. The thing is, I've seen these terms used interchangeably and for different things. So even among pathologists, there's no clear understanding or agreement as to what constitutes lupus vasculopathy versus other terminology. So if you scroll to the next slide. This came from a recent paper. So looking at the classification of lupus vasculopathy, there's a really long microscopic description, but this is the first time where they do acknowledge the fact that you can have many of these different types of vascular lesions, either in the presence of immune complex deposits or without immune complex deposits. And again, I feel like those two situations are a little bit different because they might point to different pathogenic mechanisms, but those all fall under this, term of lupus vasculopathy. So if you scroll to the next one. So here are just some of the ways histologically that they manifest. So panel A is arteriosclerosis, which I think is silly because you can have arteriosclerosis in the complete absence of lupus. I mean, lupus didn't have to cause this. I think that's something that we can argue about. Panel B is what they call sort of the uncomplicated. The immunofluorescence up top is the uncomplicated, meaning just the immune complex deposits in the vessels. And then next click. On the right, panel D, that's true necrotizing vasculitis, right? So you have fibrin, which is in the inside surface, and then you have inflammatory cells. Note the color of the fibrin, how bright red it is. Compare that to class C, which is right next door, and they call this, what do they call this? Non-inflammatory necrotizing vasculopathy. To me, I don't actually see fibrin here. What this looks like to me is just immune complex deposits without any associated, manifestations. So again, the terminology is a little bit different. I've seen people call panel D lupus vasculitis. And then if you click to the next one.
So C is what we're seeing.
C is a lot of what we're seeing, but we're also seeing, next click, very focally, E, which is true thrombosis, right? So that's thrombotic microangiopathy. And I've seen people call this lupus vasculopathy. And to me, vasculopathy means vessels with something wrong with it, right? Which can include any one of these different things. I suppose that I was just trained to call lupus vasculopathy that if there is thrombotic microangiopathy. I was not trained to call just the immune complex deposits themselves without any complications lupus vasculopathy. So there are different terminologies, right? And even as pathologists, we can't agree what they look like. We can't agree, what to call it. So I'm actually working with some folks up at Stanford and other, centers on the West Coast to look at cases of lupus vasculopathy to see if we can better define at least the pathologic features. The clinical outcome and stuff will go to, we'll hand that back to the clinicians once we get a good, pathologic definition.
But we saw E in only one glomerulus, correct?
Yeah, and that's really interesting because it looks like to me, based on the biopsy findings, that the thrombosis in the kidney is a really recent event. It has a lot of immune complex deposits in these vessels that may have just been sort of priming this kidney for thrombosis because only one out of all the number of arterioles that we saw with these immune complex deposits had a thrombosis. So it's a very, very focal finding. And I did not see anything that looked like necrotizing, vasculitis. I think that's
certainly would have expected more given the brain and the eyes and everything.
Yeah, but I mean,
it speaks for the pathophysiology, I think, a little bit.
Yeah, there could be other small vessel damage happening outside of the kidney that may, that it may explain a lot of systemic causes. I don't think we have time for this. We can just skip through this. Okay.
So back to the patient. This is what happened. Here she's admitted late August. Almost immediately after she's admitted, her hemoglobin falls from 9.8 to 6.4 in like 2 days. Her platelets drop to 60,000, her LDH goes up to 328, and her haptoglobin is now less than 8. These are the tests that came back all negative, ANCA, cryos, glycoprotein. So we kind of know from our pathology that these aren't clots. These are immune aggregates that are going on here. But she's developing severe, no schistocytes, I would tell you, but haptoglobin's dropped considerably, LDH is up, consistent with a microangiopathic hemolytic anemia. So I want to put this out as poll number 2. I mentioned this before. We did order a genetic component panel that's sent off to the Mayo Clinic. But right now, given the fact that things are getting worse, would you start Plex? Would you try to get eculizumab approval? And we'll run the poll. I think, yeah, good. So A, no for either. Yes for Plex alone. Yes for eculizumab alone. yes for both now, or I would say, let's just wait for the Mayo complement panel to come back and decide what to do.
I assume this is in addition to whatever immunosuppressive therapy she was getting.
Yeah, and we'll get to that in a second. Thanks, Steve. So we'll show the poll. We've got 44% saved for both now, 36% Plex alone, 1 for Clozumab alone, and 4 people want to wait for the complement panel to come back. I'm going to go to another question here. What immunosuppressive regimen would you choose on this woman? MMF with Blimumab or voclosporin, or the NIH cyclophosphamide protocol, 1 gram every month for 6 months, or however long. Urolupus, a much lower dose of cyclophosphamide, or an anti-CD20 regimen, either rituximab or binatuzumab. All right, we can close that. The number one choice, interestingly, is urolupus, and everyone else is about tied for the same at about 20%. So the number one is a urolupus protocol. Bill, very quickly, what would you do with poll 2 and 3 as far as Plex, eculizumab, and your choice of immunosuppression?
Well, I think being at Rush, it'd be hard pressed not to mention a pretty decent study in 1992 showing that plasmapheresis was ineffective in the setting of lupus nephritis. But I would absolutely use plasmapheresis right now, right away, in this case, because this is not our standard lupus nephritis that was in that trial. We've got enormous immune aggregates that are well, I don't know if they're going to be removed, but the best chance of them being removed would be with plasmapheresis. Get them down.
There's no cryo though, Bill.
Huh?
There's no cryo.
No cryo? I know, but I can't think of anything that might improve complements right away, lower double-strand DNA, get rid of immune complexes out of the system right away than plasmapheresis. It might be ineffective, but I would certainly do it. And then the real question is, what would stop the production of these things in the future? And I don't know that this is necessarily a complement-mediated driven process of the alternative pathway. I would probably vote for some form of complete total body suppression with cyclophosphamide, and I'd have to think about the dose. It might also depend on how bad her renal function gets. You've got to dose it for whatever her GFR is. I know her creatinine we last checked was 1.3, but I cannot imagine that it's going to stay 1.3 very long with what this looked like.
Bill, the fact that there was massive C1q deposition, doesn't that speak in favor of a classical pathway activation?
Yeah, that's right. That's right. I just don't know if eculizumab is, nothing's been studied in this type of situation. So I would probably pick for the most generic overall suppression I could possibly get, not knowing exactly what I would be, to make sure that no matter what happens, these things aren't being produced anymore. And to me, that's cyclophosphamide.
These aren't complement thrombi, right? These are immune complexes.
Right.
Well, they also do stain for complement split products too. They stain for C1q as well. And actually, early studies showed that these immune thrombi and lupus nephritis were stained very strongly for C4d, actually, which is, more evidence that there is a classical complement pathway component to the glomerular immune complex deposition anyway.
Bill and Steve? Bill and Steve?
Uh-oh.
Can you hear me?
Yeah,
yes,
we can.
Yes.
This is going to really irritate you.
Oh, God.
I'll let Steve take it.
I would plasma exchange this person from day one.
No, exactly what I said.
This is not, as Bill alluded to. I've looked at all those cases in the 86 cases in the lupus study. This is not that. They were looking at diffuse proliferative, class 3s greater than 50%, which is class 4 essentially now. Of course, we call them segmental. and then the 4 globals. This is not that. They didn't have these kind of immune complex mediated or immune complex thrombi throughout. I mean, there might have been the occasional one, but nothing like this. This is a completely different animal. And even Ed would probably freeze this person from the get-go when they have all of this kind of catastrophic extrarenal involvement, if you will.
That would be my number one. I mean, I would start plasma exchange before anything.
Yes,
I think
agree.
this patient needs that in a big way.
Dick, I think you're so right. What else would you do after that to immunosuppress?
I'd give bortezomib. I'd give some rapidly acting anti-plasma cell, anti-antibody therapy. So I would almost treat this patient like a myeloma patient.
I was just going to say, proteasome inhibitor, huh?
Proteasome inhibitor and plasma exchange.
Hmm.
Who knows? I mean, nobody's treated a patient like this before in a systematic way, so
yeah.
You could use anything.
So, Bill, what about the plex in the context of the microangiopathy? I mean, she's acting like an HUS or a, you know.
She is, and the data on that, of course, is stronger with TTP if you have ADAMTS13 deficiency, which we don't. So, but there are some cases of even in complement-mediated HUS where, you know, if it's antibody-driven, that plasmapheresis may help. Again, not studied systemically, but I was kind of just thinking to remove the immune aggregates.
Yeah, fine.
I may be wrong. I'm not saying.
No. Now you won't. I mean, who knows? But you know, I looked at this case as like this is not an MMF case, and I think everyone kind of agrees with that. You know, MMF has kind of taken over for lupus nephritis, but this is not an MMF case to me. You know, getting back when Steve said Ed to all of you, that's Ed Lewis, who was the PI of that plasmapheresis trial. Ed used to joke about CellCept being a cytoxan light, and you know, I think the results are really good for MMF, but I don't know that anybody wants to take a chance on giving a less than optimal therapy.
Well, I mean, Tak Chan might disagree with you, but again, I'm not disagreeing with you, but because I would go to cyclophosphamide too. This is just a very different animal than the diffuse proliferative GNs that Tak Chan wrote about, and again, even the lupus trial. As you've alluded to on numerous occasions with this case, this is pretty amazing.
So this is the plasmapheresis study that's already been alluded to, and basically it was a negative trial. But as was very well pointed out, I don't think that has anything much relevance to this case, either because of the severity or the fact that maybe this this microangiopathy is playing a role that we might want to plex for that. So here's what we did. We started plex immediately and did 5 days in a row and held off on cyclophos. We chose for urolupus. We gave the lower dose after pulse solumedrol, and you could see the LDH, is continuing to rise. But finally, at some point, the LDH comes down nicely, and after we stopped, and this is after we stopped the plex, it started going up again. So and if you look several times here, when we stopped the plex, it would go down with the plex, and then it would come up again. So it really seemed like it was responding to plex. I don't know what we were doing, quite frankly. It's not like TTP where it was obvious, but it seemed to really respond. So we just kept it going. Every couple of days we kept it going. Meanwhile, she got her cyclophosphamide, and here's when she went home to get continued cyclophosphamide as an outpatient. And I'll show you what else happened. Here's the haptoglobin. It took quite a while for the haptoglobin to come up. We just kept plexing her. The good news was at least that the LDH was coming up, and I'll show you the platelets in a little bit too. So we just kept plexing her like crazy. And finally, the haptoglobin started to normalize. Now, it's also may be that the cyclophosphamide kicked in. We don't really know. But I have to tell you that, it seemed that all these parameters seemed to improve when we would, after plex, and would get worse a couple days later.
The LDH was going down, not going up, right?
The LDH was, the LDH went down.
Yeah.
Exactly. Here it went down, and then we stopped plex, and it went up again. Exactly. And here's the hemoglobin and platelets. These are, she was requiring transfusions. Her hemoglobin she was so much hemolysis. And so you can see though, the hemoglobin, starts rising, and the platelets finally come up after, they're rising completely, consistently here, and finally get up into, the several 100,000. And so at some point we stopped Plex because at this point, you know, her hemoglobin was good, her LDH was good, her haptoglobin had normalized, and we stopped Plexing her. I think she had 2 outpatient Plexes after she went home. So a really nice response. And here's our serum creatinine. So we actually, one point, we did 1 CRT with clearance, 1 scuff for fluid, and then another regular hemodialysis. So you can see her creatinine went down with each of these, and just kept climbing up again. But then finally just suddenly opened up and started coming down really nicely to the point where now her creatinine's about, I think it was 1.8 the last time we checked it to be, and I think she's still coming, you know, hopefully she's still coming down. I don't know. And here's the last thing to show is her proteinuria, which is, I think, quite remarkable. She went from 14 grams, 8 grams, 1 gram, and she's sitting around 1 gram already. So I don't know what we were doing with Plex. I'm not sure what we were actually
Roger,
removing, but I was, in my mind, I was kind of treating it like a atypical HUS. Yes, Bill?
I was just saying that, you know, I mean, the LDH and the platelets and all that, you know, you think about those in, you know, platelet-rich thrombi, you know, the classic complement-mediated HUS, or maybe a TTP-type mediated HUS, where von Willebrand's factors, you know, grabbing all those platelets and doing that. And we weren't really removing that. Platelets, I'm sure, were consumed because of all the endothelial cell damage. And so that's not necessarily a bad marker to follow, but it's not like we're removing with plasmapheresis. I think just getting the immune complexes out of there is allowing the platelets not to be consumed as much anymore, as opposed to you removing a platelet thrombus or something.
Yeah, you keep going back to that, but remember her cryos were negative. I mean, obviously they're in her blood, but they're mostly in her kidney.
Yeah, but they're not platelet thrombi, is my point. Is that something like, I mean, that what I'm getting at is I'm not sure eculizumab, I don't really know, but I don't think that eculizumab has much of a role here, whereas it may if it was a complement-mediated HUS.
Well, I'll tell you what we did is, I mean, clearly we started plexing and we tried to get approval, and we finally did get approval for eculizumab, but it was long after she'd gotten better. And so, you know, we kind of dropped that. Dr. Reen, you raised your hand?
Yeah, we have a similar patient we are treating. I was flabbergasted that there are 2 patients in a row in our group. And actually we did cyclophosphamide, steroids, and Plex first, and then continued with the immunosuppression. But we treated with eculizumab, and we were able to take off Plex, and she continues to on immunosuppression, doing much better. But it took about a month and a half for her to improve. A similar position, convulsions, papilledema, and whatnot, similar kidney biopsy. So we did use eculizumab. Now thinking back, I just like Dr. Glassek's suggestion. Maybe we should treat her as with an anti-myeloma type of therapy.
Now, I have a problem with that, and that has to do with the B-cell rebound, which follows pheresis. As you remove the immune complexes, the B-cells begin to act up. And clearly, cyclophosphamide will work in that regard, but I'm not sure bortezomib will work.
Oh, bortezomib will work beautifully.
For B-cell rebound?
Oh, yeah, sure.
That was the rationale actually behind using cyclophosphamide in the lupus trial. I mean, at the time, they were using just high-dose prednisone, and Ed always said the reason they gave cyclophosphamide to the patients that didn't get pheresis was because they had to use it in the pheresis group or they would have rebound. So the standard treatment group actually ended up getting prednisone and cyclophosphamide alone. It wasn't because Ed felt that they needed to get cytotoxic therapy, which was interesting. Gene, my recollection was there was diffuse effacement. Is that not true with the podocytes?
There is diffuse effacement, but that was in the setting of membranous. You know, so we often see diffuse podocyte process effacement with significant subepithelial deposits. In a case like this, I don't think I would have felt comfortable given a separate diagnosis of like a lupus podocytopathy, for instance.
That's
because
fine.
you can, yeah.
I just only bring it up because she went from a couple grams to 14 grams of proteinuria, and some years ago, Bill in membranous, thought it was membranous lupus, showed the association between diffuse effacement and, the disassociation, I guess, between the volume of the deposits relative to the effacement.
Mm-hmm.
And so you could have a lot of deposits, but if you didn't have diffuse effacement, you wouldn't have a lot of proteinuria. And I was just, my recollection was, in addition to the microvillus transformation, there was a lot of effacement as well, which may account for.
Yeah, that's a good point, Steve, because the proteinuria did get better fairly rapidly.
Gene, was there reduplication of the GBM in this case? I thought it was.
There were, but they were associated with the subendothelial deposits. There was no GBM duplication that was indicative of like a TMA.
Okay.
I don't have access to the chat right now, so if anybody, if somebody sees anything that's important, just bring it up for me. I'm running the screen for fear I had to leave. I can tell you, if we could have had eculizumab, I would have given it, but it's, pretty much requires an act of God at Rush to get it as an inpatient. I don't even know if we can give it as an inpatient. I think that we were getting approval for an outpatient, but fortunately that wasn't it didn't have to happen because she got better with our treatment.
Did her complement sticks ever come back?
View, I wouldn't give this patient eculizumab. The problem is it's not going to do a whit for the formation.
I don't know. I don't know. That's fair, but I don't know why the response to Plex was so remarkable that maybe I'm lumping too much, but the response to the Plex was so remarkable that it seemed to me that would be the next step. And but
what did the Mayo studies show?
Yeah. Oh, well, it's funny you would ask that. So the Mayo comes back much, much later, and the result is there is a variant of unknown significance detected. It is a deletion of the CFHR3 gene is classified a variant of unknown significance, but it encodes a complement of H-related protein 3. And you can read all of this, but basically, preliminary evidence suggests pathogenic variants in this gene may be associated with susceptibility to an atypical hemolytic uremic syndrome. So I don't know. I mean, she may have an underlying genetic abnormality that's kind of somehow playing into this whole thing. They're not sure if it was significant or not, but I can tell you it wasn't negative. And I don't know, again, even if she had it, if there's a role for Plex in that or not. But it was interesting that this did come back positive in the end.
Was there upregulation of the MAC or no? Sometimes you'll see that as well.
They didn't mention that, no. So it was not negative, let me put it that way. But it comes back, and I think these decisions have to be made pretty quickly. If you could order eculizumab like rituximab, maybe Dick's right, it wouldn't have done anything. But we were all over the place with our heme and our room and ourselves. And fortunately, the one thing even though I didn't know what I was doing, why I was doing it, I felt very strongly about Plex, and I don't know if it helped or not. But she did. Considering that biopsy, I think she's doing pretty well. Considering somebody that had 6 seizures, AKI, and everything else, she did great.
Like what Bill Whittier said a few weeks ago about the defects in the ISN-RPS classification system, if somehow a biopsy report appeared in the chart saying this patient has class 4 lupus nephritis, would this patient have gotten plasma exchange? Probably not, because the notion is you don't treat class 4 lupus. But this patient never had class 4 lupus in the first place. This patient had a vasculopathy.
And the scary thing is sometimes they won't report
myeloma cast nephropathy intervescens.
Sometimes the pathologist won't report a diagnosis of lupus vasculopathy unless there are complications like thrombosis or vasculitis. Just the presence of the immune complex deposits alone is not enough in some pathologists' eyes to warrant a diagnosis. Right. So without raising that flag,
And along the same lines, we talk about seeing the path yourselves. Those pictures, are worth 1,000 words, and not the same words that are in the description. It's just, like I said, I'd never seen anything like it. I'd never seen that degree of subendothelial deposits that include. I also have never seen vascular involvement like that. I mean, it's just absolutely incredible.
But the subendothelial deposits weren't occluding. It was the intraluminal deposits that were occluding, right?
Well, the subendothelial deposits that grew so big that they grew down to occlude.
Those were subendothelial that just grew to the point of being...
Because in the one picture that you showed, there was a subendothelial deposit on the EM, and then within the lumen was a separate deposit, I thought.
It was just the way that particular section was cut. I think that if you seriously section enough, you can pretty much almost always prove that these are actually originating from a big subendo deposit.
Now,
Okay.
Roger, I have a few points. Number one, kudos to you and the team of thinking about ferricin. I mean, that was the right thing to do from my point of view. Number two, if you had the old Raji cell assay for circulating immune complexes, there would have been a load of circulating immune complexes. And number three, I'll ask Dr. Glasser to please share the reference about bortezomib and rebound B cells. I'd like to be educated on that one.
Okay. Will do.
We'll get that out. Any other comments? I mean, this is 30 minutes over, but I got to tell you, this is an absolutely incredible case. I can't thank everybody enough. I think she got lucky that she was in California. We got lucky that Dr. Howe has been part of this, both for the case and going to a place like that, and now with our conference. Gene, thank you so much. What a great conference, and appreciate everybody. We're going to be off for a while. We got Thanksgiving, and then I'm going to be out of the country, but we'll let you know when we're back. We'll get this thing posted up on our YouTube channel shortly. And thanks everybody for coming.